Friends or colleagues, or abnormal eyelid contour. Elderly patient with progressive ptosis might complain of decreased vision or visual field restriction. It is very important to address the patient complaint because it is not uncommon that the patient has pseudotosis due to shortening of the pretarsal jaw with hooding of the skin or other etiologies. So what I'm doing in my clinic, I give the patient mirror and the Q-tips and let them to point out where is the problem. It is frequently that the hooding of the skin, like the first photograph here, or maybe so severe blepharodermatochalasis or brow ptosis, that this is a major problem and not actual ptosis or true ptosis. There are some questions that you have to address at the end of your evaluation. At the end of your history, you have to address the etiology of ptosis. You have to rule out dangerous ptosis where imaging is indicated or referral also is indicated. As you evaluate the patient on examination, you have to decide which surgery is the most appropriate for the patient and when should you perform the surgery. Is it early, urgent, or you can delay it, or sometimes you have to avoid it. At the end of your evaluation, it is very important to have photographic documentation as well as patient counseling. So I'm going to start with the history. It is very important to remember that if you could not figure out the etiology of ptosis from the history, you have to worry about your ptosis knowledge. The first question, and simply to answer, is it congenital or acquired? And if the child is coming early or the patient is coming late, it is very easy. But sometimes, especially in mild ptosis, you have to ask for all the photos to see if the patient has some congenital element. The second, and actually most important, is the onset. Always remember that ptosis of acute or subacute onset usually hides something dangerous. And I'm gonna give you some example for these ptosis. This child has right mild ptosis, and when we examine the extraocular motility, it has some bizarre movement, and the ptosis actually is recently developed. And with investigation, he proved to have eosinophilia. Another patient who has shortening of palpebral facial height on the left side with some hypertropia, which is also recently developed of couple of months. And with evaluation, he proved to have T-cell lymphoma and he received the chemotherapy. Also, orbital inflammation or infection as well as tumors might be presented with early ptosis, especially if it is short duration or progressive in course. Then you have to ask about diurnal variation. Always remember, if you did not ask about diurnal variation, definitely you're gonna miss myasthenia gravis. And patients usually have ptosis, may be having diplopia at the end of the day, systemic features of facial weakness or weak chewing, stumble and fall. You can perform ice bath test to confirm the diagnosis in your clinic plus imaging, or to refer the patient to neurologist or neuroophthalmology to have the confirmation with the hydrophonium test. Also, history of trauma. Sometimes the trauma is not evident if the patient has wide blowout fracture. And with extraocular motility, you will be able to identify it, and you have to ask exactly about the trauma, especially in pediatric age group. Sometimes they have minor traumas, orbital floor fracture, and ptosis. Surgical trauma is also important, either intraocular or extraocular, as well as non-surgical intervention. You know, nowadays the Botox are really increasing and became popular in community, and patients usually came with just a few days of ptosis. So you have to clarify if they haven't or they have taken Botox, received the Botox. And be smart, don't ask about cosmetic intervention in front of the husband. So just take the husband outside and let your assistant ask about Botox injection. Also, if the patient had previous ptosis surgery or lid retraction, they might have pseudotosis or iatrogenic ptosis. The course also is important. Usually in congenital ptosis, simple congenital, it is a stable type. Sometimes it is improving, like medical third nerve palsy, or getting worse with involutional type of ptosis or other dangerous type of ptosis. Family history is also important, including the medical and anesthesia history. In pediatric age group, ask about congenital heart disease because it is higher incidence associated with congenital ptosis too, as well as malignant hyperthermia. If the patient has blepharophimosis syndrome, it is autosomal dominant, and as I showed you here, there is the ear ring, so it is very important if it is female to refer her for early ovarian failure. So at the end of the history, you figured out the etiology, you picked up dangerous ptosis, and when imaging is indicated, mostly you decided whether you need to refer the patient or not, and you filtered also cosmetic induced ptosis. Now we'll go for examination. In pediatric age group, it is better before touching the child, so he won't to cry, and then you'll not be able to get any data to check if the pupil is covered by the ptotic eyelid or not. Very simple issue is just to hold the ophthalmoscope and try to see the clear reflex. And always remember to be on the same level of the child. Then you'll go for the most important parameter for the choosing the type of surgery, which is the vital eyelid sign, including the palpebral fissure height, the distance between the upper and lower eyelid, MRD1 between the upper eyelid and corneal light reflection, and MRD2. Then look at the lid crease shape and height, because if the lid crease is formed, mostly the levator is not poor in function. And it is one of the important parameters to diagnose aponeurotic ptosis if the lid crease is high. The levator function is also very important, which is the movement of the eyelid from the extreme down gaze to the extreme up gaze, what we call it lid excursion. And always remember when you measure it to fix the eyebrow, otherwise you will have accentuated measurement. So it is very important to fix the eyebrow. As you can see here, it is between 40 and 45, and here also is the same parameters. Then in congenital ptosis, interestingly, the eyelid, when the patient is looking down, is slightly lagged. So what we call static lid lag, to differentiate from the dynamic lid lag with the thyroid. You can see the ptotic left eyelid is higher in position than the normal one. Then when should we operate? Usually in pediatric ptosis, we operate at the preschool age with two exceptions. If the patient has severe ptosis, so you have to avoid amblyopia, or if a patient has bilateral severe ptosis, to avoid abnormal head posture and deformity of the cervical spine. At the end of your examination, for God's sake, never forget the following. The first is ask the patient to chew or to move the mouth sideways or anteriorly to rule out Marcus ganglia winking phenomena, because the surgical intervention here is completely different from simple congenital ptosis. The second is the extraocular motility. If the patient has third nerve palsy and he has diplopia, if you correct the ptosis, he will never forget this for you. And also there is some extraocular motility abnormality with the eyelid movement, what we call it third nerve synkinesis. So you have to evaluate the extraocular motility too. Also in chronic progressive external ophthalmoplegia, the patient hasn't diplopia, but he has progressive limitation of extraocular motility, and we will see with Dr. Varity what is the best option for such a patient. Don't forget to assess Bell's phenomena by trying to open the eye while the patient is closing his eye. If the patient has decreased Bell's phenomena, like this patient, if you operate him, he might have corneal problem, exposure keratopathy, and this patient ended up with even dysmatosy. Also, look at the pupil in mild ptosis. This patient has Horner syndrome, and we imaged him on spot and proved to have dissecting carotid aneurysm, so it might be fatal. So never ever forget the pupil if you have mild ptosis. The hearing is low. You can see here this patient has left the ptotic eyelid. When we elevated the ptotic eyelid, the other eyelid is drooping. And you can see this video here. While we are holding the ptotic right eyelid, the left eyelid is going down. This is very important to counsel the patient about the post-operative result he might need for another surgery. You might go for bilateral procedure on the same setting or in consequences. Also, don't forget to manage, detect and manage amblyopia, and you should have clear plan for further management after your surgery. The ocular examination is also mandatory. You can detect for this patient the down photograph. She has vacancy, and this is a panoramic type of ptosis. This patient has left carotid cavernous fistula with corkscrew vessels. At the end of your evaluation, you have to spend time counseling the patient for ptosis surgery. Otherwise, you'll have a lot of concern post-operatively. As you know, lag of thymus and lid lag is a side effect or consequences of ptosis surgery rather than complications. So you have to discuss with the patients or family the need for use of lubricant after surgery, and if the Bell's phenomena is defective, the patient might have exposure keratopathy. And also, don't forget to discuss with them the possibility of the need of redo or reoperation. So after examination, you picked up dangerous ptosis and referral. You decided which type of surgical procedure is indicated according to the levator function and associated syndromes, and when early or urgent management is indicated, and when you should avoid surgery. So in summary, acute or subacute ptosis in any age group are often dangerous, and imaging is mandatory. Congenital ptosis are not always simple. Myasthenia gravis and jaw winking are frequently missed if you did not ask during history. Always look at the pupil size and in mild ptosis, and never ever miss extraocular motility, Bell's phenomena, and healing slow. And recent Botox injection should be routinely clarified in any recent developed ptosis in adults. Thank you.
Thank you so much, Dr. Yasser, for a very nice presentation. And now we'll move to the second speaker, Dr. Miguel Gonzalez. He will speak about controlling tarsal platform show, lead margin, and contour in ptosis surgery. Because we all sure that ptosis is not just a functional procedure, it's also a cosmetic procedure. So Dr. Miguel will speak about the contour and how to manage the contour. Please, Miguel. Unmute your audio, Miguel, please.
Okay. Thank you very much. This is Dr. Miguel González Candial from Barcelona. I'm currently in private practice only at Oculoplástica Barcelona in Clínica Tecnon in Barcelona. And thank you, Andrew Wahid from IVA Pharma and Dr. Tamer Caudat for organizing this webinar in ptosis. Elevation is probably one of the main goals in ptosis surgery, but is not the only one. And symmetry, contour, and adequate tarsal platform show should be considered within the goals of a ptosis surgery. Most studies consider adequate tarsal platform show between 2 millimeters to 3.5 millimeters. It's difficult to predict the final tarsal platform show due to the final upper eyelid brow dynamics and ptosis surgery, after ptosis surgery. To do that, it's very important to take the right pre-op measurements and asymmetry, detect any asymmetry, recognize the factor that determine the final tarsal platform show, and design the surgery to address the ptosis and the upper eyelid brow complex correction. The relevant pre-op measurements, as my colleague mentioned, are the pupil aperture, the MRD1, the levator's function, skin crease, the TPS, tarsal platform show, and to check if all the protective mechanisms of the ocular surface are conserved, like the orbicularis function and the Bell's phenomenon. You have to detect if there is any lack of thalamus or any retraction. And remember the Herring's law that may affect the contralateral eye, and the other side may require Ptosis surgery as well. Consider also the correction of the dermatochalazion and brown ptosis at the same time and predict the brow descent. You may have a patient like this one walking into your office asking for a ptosis correction on her left side. And when you take the measurements, you see that the palpebral aperture is 9.5 in both sides. The MRD1 is 4 in both sides. The skin crease is asymmetric. It's 9 in the right side and 7.5 in the left side. The anterior lamellar is also asymmetric. It's 22.5 in the right and 22 millimeters in the left. And the lid lag is 4 and 3. And the TPS is 2 millimeters and 4 millimeters. So the patient hasn't got ptosis, but has got an asymmetric tarsal platform show. The factors influencing the final TPS are the position of the eyelid margin. A higher margin lowers the fold. The position of the eyebrow. If the eyebrow descends, then the fold will come down. The amount of skin. So if we remove skin, that may raise the skin fold. The position of the skin crease. The higher the skin crease, the higher the fold, and the amount of protruding fat. Depending how much fat we remove, that may cause some upper eyelid and brow descent, or if we remove too much, that may cause a marked increase in tarsal platform show. Asymmetric appearances in patients with ptosis is mainly caused by the difference in tarsal platform show between each side. So what we detect is the asymmetry in TPS more than the degree of ptosis that the patient has had, or the patient has. For example, in this patient, she has got ptosis in the left side, but there is some symmetry in the TPS, which camouflages the degree of ptosis that she has. On the other hand, this patient has got a very mild ptosis, but there is quite an asymmetry in TPS between both sides. And that allows us to perceive as if she has more ptosis than she really has. In this patient, as we just saw, there is no ptosis on the left side, but there is an asymmetric tarsal platform show. Why does the TPS change in patients with ptosis? Traditionally, senile ptosis is thought to be caused by the levator's aponeurosis insertion, but we know that the eyelid is held in primary position by the Mueller's muscle. The Mueller's muscle elongates with age and other factors, and then the eyelid margin descends in primary position. In more advanced cases, then the aponeurosis may disinsert. The skin crease elevation is caused by the elongation of the Mueller's muscle. There is an increased tension that are attached to the skin, and there is an increase in tarsal platform show. In cases of mild ptosis, this asymmetry may become worse by the compensation of the frontalis muscle, raising the eyebrow. That may increase the tarsal platform show in this side with very mild ptosis. So it's very important to planning the surgery and to consider the brow fat span, the tarsal platform show, and the marginal reflex distance in all patients undergoing ptosis surgery. This patient has a very, very mild ptosis, as we mentioned before, but a very asymmetric TPS, tarsal platform show. Which are the parameters that determine the surgical correction of ptosis? Well, we all know that the main factors that we check to determine the surgery are the levator muscle function and the amount of ptosis correction. And the most common procedures in ptosis surgery in cosmetic patients are the Mueller's muscle conjunctival resection and the anterior approach aponeurosis advancement. This patient had a bilateral ptosis correction through an anterior approach aponeurosis advancement with good symmetry and symmetric tarsal platform show. But how do we design the surgery to address ptosis and upper eyelid brow complex correction? Well, if the tarsal platform show is longer on the side with worse blepharoptosis, then, well, we apply ptosis surgery in that side, and then we correct the asymmetry in tarsal platform show. If there is symmetry in tarsal platform show despite the asymmetric ptosis, then you have to think that there may be some changes in the bone or some soft tissue asymmetries in the more apoptotic side. In that case, when you are planning to correct the surgery in this side, in the left side, in the case of this patient, you have to think that the skin at this level may become redundant, and you may need to correct that, or you may need to address the position of the brow, depending on the patient. In cases where there is an asymmetric fold but with no ptosis, these are cases more difficult to correct in some cases. And you can address the skin crease by raising it. You do that by performing 3 millimeter horizontal incisions at the level of the desired crease. And then you place 3 double arm mattress sutures from the tarsus to subcutaneous tissue. You may want to lower the crease, let's say from 9 millimeters to 6 millimeters. Then you perform an excision of the skin and orbicularis, and then you bring down the fat to the level of the new incision in order to recreate the fold. In some cases, you may need to consider surgery in the other side, like blepharoplasty. And also you may need to consider the repositioning of the brow. You can do that by performing a brow lift, or using some Botox, the frontalis, or by using some fillers in cases where there have been some fat deflation at that level. Botulinum toxin application to the pretarsal orbicularis oculi muscle can be used to correct very mild ptosis. I usually inject 2 injections of 1.25 units at the level of the eyelid margin in the junction of the central third with the middle third, and in the central third with the lateral third junction. And apraclonidine has also been shown to be effective to temporarily correct the mild ptosis in these kind of patients, as we can see in this image. Controlling the contour can be quite challenging. You have to be familiar with the racial variations in your community. And we know that in Caucasians, the maximal aperture is at the junction between the medial third and the lateral 2/3. Usually both the levator advancement and the conjunctival amerectomy provide a good result in terms of contour. If there are some pre-existing contour anomalies, I prefer to use the anterior approach, and I usually place 3 sutures, one at the level of the medial pupil, another one at the level of the medial limbus, and another one at the level of the lateral limbus in the tarsus. In summary, if the tarsal platform show is longer on the side with worse blepharoptosis, then you go ahead and you correct the unilateral ptosis surgery, and that will improve the symmetry. If there is symmetric tarsal platform show despite asymmetric ptosis, then apart from the ptosis surgery, you have to consider blepharoplasty and brow lift. And in cases where there is an asymmetric fold with no ptosis, you can address the skin crease or raising it or lowering it, and you can use, or you can perform blepharoplasty and modification of the brow positioning and volume. When you are planning ptosis surgery, you have to address or to check the brow fat span, the tarsal platform show, and the margin reflex distance, mainly if they are cosmetic. Thank you very much.
Now we will proceed to next speaker, Dr. Michael Yam, professor and the Sarah Campbell Laffer Chair in Ophthalmology, Colin I Institute, Baylor College of Medicine, Houston, Texas, United States. He will speak about mechanical and paralytic ptosis. Please, Dr. Michael.
Thank you. Can everybody hear me? Great. Well, thank you very much to Eva Pharma for sponsoring this wonderful program, and thank you, Dr. Hammer, for the invitation to speak to you all. So what I'm going to be talking about today is mechanical and paralytic ptosis. And you know, when you look at the different types of ptosis, you have aponeurotic, myogenic, and then we have the neurogenic, paralytic, and mechanical ptoses. And we really don't talk about mechanical and paralytic ptosis very often because we just don't see it as often as we see the age-related aponeurotic ptosis. But I feel like it's an important conversation to have, and it's an important topic to talk about. I feel like I'm seeing more and more of mechanical ptosis and paralytic ptosis, so it may be more relevant in your practices nowadays as well. So, and you can see mechanical ptosis, like in this patient here with this large chalazion pushing down on the eyelid. So I'll start off with paralytic ptosis. So several different causes of paralytic ptosis. Obviously, the most obvious is going to be a third nerve palsy, and that can be caused from either tumor, stroke, or trauma. We can also have a classified as paralytic ptosis, Horner syndrome, congenital jaw winking ptosis, where the patient, such as in this child here, where they have a ptosis, but when they move their mouth or muscles of mastication, they can end up with elevation of the eyelid. Myasthenia gravis, many people would consider myasthenia either a neurogenic or sometimes also a myogenic ptosis. It's kind of in the neuromuscular junction. And then, of course, botulinum toxin-induced ptosis as well, kind of neurogenic or sometimes also considered myogenic as well. So how do we manage these patients who have paralytic ptosis, or what are some considerations that you should have? Well, if the third nerve is not functioning, pretty much you are left with just doing a frontalis suspension because you need to recruit a different muscle that is innervated by a different nerve to elevate the eyelid. Special considerations, though, when you're performing a frontalis suspension for a third nerve palsy, patients with third nerve palsies oftentimes also have strabismus and diplopia because of the ocular misalignment as well. So elevating the eyelid can make that diplopia much more symptomatic for patients. And likewise, if they have poor motility, they may oftentimes also have a poor Bell's reflex. So elevating the eyelid, if you end up with a lag ophthalmos, even with a small lag ophthalmos, can lead to corneal exposure and keratopathy as well. Sometimes in patients who have a third nerve palsy, I'll oftentimes consider a ptosis crutch for them, which is just a sort of modification to their spectacle lenses that will manually and physically lift the eyelid just to give them a trial, just to see how they can tolerate having the eyelid elevated before performing surgical correction. Patients who have a Horner syndrome, I love performing a muellerectomy on patients with Horner syndrome. I think they usually have excellent outcomes. Jaw winking ptosis oftentimes responds well just to traditional ptosis repair. And you know, I oftentimes don't do very much special for the winking portion. Now, I do tell the parents that the winking may persist, and if that truly is bothersome to the parents and the patient, you may need to consider extirpating the levator on both sides and then performing frontalis suspension to give symmetry. And this is just another patient who has jaw winking ptosis. You can see that as they open their mouth, the eyelid becomes much more retracted. And then for the, as was mentioned in the in our previous talks here, patients who have botulinum toxin-induced ptosis oftentimes will respond very well to aproclonidine. And now I'm going to talk about mechanical ptosis. And you know, mechanical ptosis seems to be very straightforward. It's just something that is physically preventing the eyelid from elevating. And that can be either from an eyelid lesion, orbital lesion, sometimes periorbital inflammation or infection causing lid edema can cause a mechanical ptosis. And then trauma can cause a mechanical ptosis as well. And here's just a MRI scan of a patient who has a myositis of that superior rectus levator complex that was resulting in a mechanical ptosis. So just talking about eyelid lesions can be very benign, such as chalasia. That's probably every single day in my clinic. We see patients that have chalasia. Patients, infantile hemangioma, patients, if it's on the eyelid, can certainly present with a ptosis. And here the consideration is if it's obstructing the visual axis, you'll want to treat that hemangioma either with beta blockers, oral beta blockers, or if not responsive, corticosteroid injections, or with surgery to prevent the development of occlusion amblyopia. Plexiform neurofibromas, oftentimes in patients with neurofibromatosis, can also present with a mechanical ptosis. Then going into malignant eyelid lesions, severe, doesn't even have to be as severe as this, but any type of lesion, but a basal cell is the most common eyelid malignancy. And here we have a patient who has a severely neglected basal cell that's resulting in a mechanical ptosis. Other types of eyelid malignancies and also systemic or metastatic lesions can also result in a mechanical ptosis if it's involving the eyelid. Here, this is just a patient who has a sebaceous cell carcinoma that really does not look very obviously large, but is involving the eyelid enough where it's causing a mechanical ptosis. Anterior orbital lesions, the most common anterior orbital lesion in children would be a dermoid cyst. This is actually a patient who has a medial orbital dermoid along that nasal frontal suture line that's causing a mechanical ptosis on the right side. A lipodermoid of the orbit can also be anterior orbit, can also cause a mechanical ptosis. This patient has a lipodermoid on the left side, and that was resulting in a mechanical ptosis of the left upper lid. Here's a rhabdomyosarcoma. It's this was taken in the operating room, so we're manually lifting both eyelids, but you can see the large mass on the left side that was causing a mechanical ptosis. You can have lymphoid infiltrates like lymphoma. This patient has a lymphoma of the left or of the right lateral orbit there, causing a mechanical ptosis of the right upper lid. And then, of course, metastatic lesions can also cause a mechanical ptosis as well. Some inflammatory or infectious causes, preseptal and orbital cellulitis, obviously with significant eyelid edema, can cause a mechanical ptosis. This is a patient that I saw a few years ago who had amyloid infiltration of the tarsal conjunctiva that was causing a mechanical ptosis of the left upper eyelid. Patients who have blepharochalasis, idiopathic orbital inflammation, again, can cause mechanical ptosis. And then here, this patient has posterior lamellar cicatrization. She actually has, I believe, a prior history of Stevens-Johnson syndrome. And you can see just the mechanical tethering of the lid, preventing the lid from elevating, is causing a mechanical ptosis of the right upper eyelid. Foreign bodies, orbital inflammation, resulting in orbital inflammation can cause a mechanical ptosis. Orbital roof fractures, especially if you have that frontal bone is pushing down, impaling into the levator and complex, can cause mechanical ptosis. Restrictive, this is a patient who had prior trauma with fibrosis of the eyelid and cicatrization of the eyelid, causing a mechanical ptosis of the right upper eyelid. And this is what I actually see pretty frequently now from my glaucoma specialists. They're creating these very large trabeculectomy blebs that you can see here, and the size and the elevation of that bleb prevents the eyelid from elevating adequately, so resulting in a mechanical ptosis of the eyelid there. So how do we treat a mechanical ptosis? Well, the easy answer is just remove or treat the underlying mechanical etiology. If you have a chalazion, treat the chalazion, and that should go away, and hopefully the eyelid elevates normally. But oftentimes the answer is not quite so straightforward. Sometimes you cannot remove the lesion completely, or you have incomplete removal. Sometimes treatment leads to collateral injury. And so many patients may have residual ptosis even after optimal management and treatment of their underlying cause. So if a residual ptosis remains, I'm not really talking about the actual surgery for ptosis repair, because it's our standard ptosis repair approach. You can either do a Mueller's muscle conjunctival resection, levator resection, or an advancement. And when I do an external levator procedure, I always find that I need to do more aggressive lifting than I initially anticipated, or that I normally would have anticipated if it were just, say, an aponeurotic ptosis. Or you can do a frontalis suspension if that's what it comes to. And here I feel like when we're dealing with mechanical and paralytic ptosis, intraoperative assessment and adjustments whenever possible is a tremendous valuable aid to determining how much lifting needs to be done. So in summary, there are several different classifications of ptosis, and clearly, making that correct diagnosis is the first step to guiding our appropriate treatment. Neurogenic ptosis oftentimes involves the third nerve, cranial nerve 3, and so you may also need to have the diplopia managed. And mechanical ptosis may result from many underlying etiologies, and the primary treatment should always be directed towards addressing and removing that mechanical etiology. So that's all that I have, and thank you for giving me the opportunity to participate and talk to you today.
Yes. Thank you so much, Mike, for the interesting talk. And actually, you put your hands on something very important, that whenever you have a ptosis patient or patient complaining of droopy eyelid, we have to examine the patient palpate the eyelids. Most do not palpate, and whenever you palpate, you will find a mass. So, excuse me? So you have to palpate the eyelids to exclude any palpable lesion that will need biopsy or excision, especially in the mild cases. We'll move to the next speaker, Mr. David Verdi. He's the president-elect of British Oculoplastic Surgery Society and treasurer of European Society of Oculoplastic and Reconstructive Surgeons, consultant, ophthalmic surgeon, Moorfield Eye Hospital, NHS Foundation Trust. Please, Dr. Verdi, you can start now.
Well, thank you very much indeed for joining us. I think we have some 625 registrants. These are colleagues and friends of ours, and we thank you for being with us as we embark on this new time together in a very difficult environment that we're all living through. Thank you to Andrew Wahid and to Eva Pharmaceuticals, and thank you very much indeed to Tama for all you've done putting this together. What I wanted to do today was to share with you some of the features in silicone brow suspension, who to do it on, how to do it, and how to deal with some of the complications. And these are the problems that we face in myopathic and neuromuscular junction disease. The etiology in these patients is often very uncertain. That's compounded by the fact that while the patients have ongoing investigations, there are increasing delays, and the patient comes and goes from ocular plastics to neuro-ophthalmology clinics. Sometimes it seems like months or even years. They have a variable response to their medical treatment, and if you do operate on them, then of course there's the risk of diplopia, and this is unmasked when the lid is lifted. And the question is often whether to lift one lid or two lids. And if that's not enough to cope with, of course the disease is often progressive, and the surgical goalposts are moving all the time. And in addition, although you may want to perform this under a general anesthesia, at times it may be inadvisable due to cardiac conduction anomalies and some of the conditions. And the patients have high expectations, particularly some of those younger patients with myasthenia, for example. And if that's not enough, finally, the risk of corneal exposure is often there before we start to operate. And so when we lift these lids in these patients whose eyes don't move, we increase and we unmask corneal exposure even further. So what are the indications for silicone brow suspension? You could argue that the indications are actually anybody with a levator function of less than about 5 or less than 10 when the cornea is at risk in progressive myopathies. But in summary, we treat patients with a silicone brow suspension if they have a chronic progressive external ophthalmoplegia. So these are syndromes, and there's about 5 of them. The one that you and I are familiar with is chronic progressive external ophthalmoplegia and Kearns-Sayre syndrome. But there are various other conditions called MELAS, NERF, NARP, and these are associated with encephalopathy, epilepsy, and ataxia, and we'll test you on all those later because no one can ever remember them. And of course, Leber's. So they belong to the mitochondrial disorders, but we also have the muscular dystrophies, which is a progressive atrophy of the muscle. And the one we're most familiar with is myotonic dystrophy, but of course we also have oculopharyngeal dystrophy and fascioscapulohumeral dystrophy. And then finally, something I only discovered recently is vitamin E deficiency. And that tends to be more common in developing countries where there are fat absorption issues. The second condition that we'll be treating often with some form of adjustable silicone brow suspension will be myasthenia gravis, of course. And in the order in which they tend to be most problematic, we have diplopia number 1, we have ptosis number 2. Now the ptosis can be isolated and it can fluctuate, but eventually it tends to lead to bilateral disease. The patients often have slurred speech, impaired swallowing, neck pain, breathing difficulties, weakened grip, and so on and so forth. And of the ocular impairment, the weakness may be of a single muscle of one eye to a virtual paralysis of all muscles of both eyes, and it increases with fatigue and it improves with neostigmine. So what about then this use of silicone in brow suspension surgery? The advantage of silicone is it's readily available. It has the inherent elasticity, and that's really important when we're talking about diseases which have a tendency to progress. They're not without their problems, of course. Slippage can occur, but adjustment is possible. In the unlikely event that the inpatient has an infection, they can be removed. And although you may prefer to perform these under general anesthesia at times, they often have cardiac conduction anomalies, and therefore you're required to perform them under local anesthesia, usually with sedation, but you can perform it under general anesthesia as well if you want to. So what I'm going to describe now briefly in the time allotted to me is the so-called open sky technique. Now, when I started doing these, I performed them all with a closed technique. But I realized and learned from other colleagues that if you can suture the silicone to the tarsus, you get a more durable lift and you get a better contour too. And I hope to show that in this talk. So here you have 2 pentagons, as you've shown here. Here's the patient, local anesthesia with sedation. And we've marked out the pentagon. And the angles of the pentagon are one on the medial border of the limbus, one on the lateral border of the limbus, one just a little further out above the brow, a little further out above the brow. And this superior one does not have to be as high as I've shown here. You can have it lower in a ritted here. You can have an irrited here. I've even heard of people placing it down here, and I really don't think it matters that much exactly where you put it. But I will say this, the patients need plenty of local anesthesia, and they need often quite a bit of sedation. It's quite surprising how uncomfortable it is to anesthetize this area I'm showing you with the arrow at the moment, and down here. So I often say to my fellows, you've really got to give the local anesthesia whilst they're sedated, and you should be prepared to top them up if necessary. So we make a skin crease incision down to the tarsus. Don't forget, we're talking about the open sky technique. And then we make 3 other incisions, as I pointed out, one with the E11 blade here, deep down towards the periosteum, one further one up here, and one up here. And if you haven't done this before, don't worry if they bleed quite a lot initially. They nearly always do, but they always settle after a few minutes of gentle pressure. So let me take you through placement of the silicone band on the tarsus. And it's really fairly self-explanatory, actually, because what we do is we place 3 sutures that effectively plicate the orbicularis over the silicone onto the tarsus. And here you see the suture. But if you can't see it clearly at home where you are, I'll just make it a little clearer. The green is the external, the white dots are deep in the tissue, and the purple is the silicone. So that if you follow this through with me, you've got the 6-ovicral suture running along here. It picks up a bit of orbicularis, runs over the silicone, picks up the tarsus, back over the silicone, under the tarsus, under the orbicularis, and out again. And the effect of that is to flip this orbicularis onto the tarsus. It's a bit like a spot weld, if you like. So here you have 1 such suture. And of course, if you only did 1, you'd end up with a cathedral arch type of configuration of the lid. And that wouldn't look any good. So of course, we go for 3. And I think here we are, here are the dots. Now, the one that I showed you The first one was application of the orbicularis onto the tarsus, really very tight around the silicon and quite close to the lash margin too. But I would suggest that the medial and the lateral one are just a fraction higher. Otherwise, you might well tend to get a slightly squared lid. So there we are. We put 3 of them in. You can put more in if you like to, or if you have a redo. I tend to use 3, and I use a 6-0 absorbable suture. And then, of course, we have to use the right Ptosis needle. And you can see this here. And it's very important, if you haven't used one before, to make sure that you have your index finger, or as we call it, the forefinger, through this part of the loop. What does that do? Well, what it does is it maintains the curve always facing upwards. And we're going to place it through this incision. Initially, mind you, we're facing the angulated tip vertically downwards onto the patient, onto the periosteum before we flatten off. And we want to drive it out to come as lateral as possible, as I'm going to show you here. So I'm using the finger to remind myself of where I am at all the time. I don't want to be too deep for obvious reasons, and I don't want to be too shallow either. And so the finger is very useful. And you may think that it's an easy thing to pass. Well, I can tell you certainly in Moorfields, where the instruments have had a certain amount of use over the years, it's not always that easy. And even with a fairly sharp instrument, it does require a certain amount of energy and isometric pressure to drive this needle forwards, always, of course, with a corneal guard underneath, as you see here. And here you see the tip, it's just come out. Very important at all times not to manipulate the silicon with anything sharp. That's including a toothed forceps, and don't manipulate it with a rather sharp right fascial needle, as you see here. And the balance that has to be achieved is to keep this track deep enough to stay away from the conjunctival fornix, but also not so shallow that you start to get a little bit of puckering. And if I was to be critical of this photograph, I would say that arguably it's slightly on the too shallow side. So there you see where the needle's gone through. And here you see me holding a pair of St. Martin's forceps, and there's the end of the silicon. You can't quite see it, but it's about to be placed through the eye of the needle, just fed through like that. And then when we draw it back through, and perhaps this is my natural anxiety in preventing infection, but I found it helpful to hold a cotton bud soaked in iodine, held just under the tip of the needle. Then as you draw that needle through, of course, it draws a light layer of iodine which coats the silicon and helps hopefully to reduce the risk of infection. And here you see it being done on the other side again, still got the lid guard in place, still got a new cotton bud there with iodine, and that's being drawn out into the brow area here. And the nice thing at this point is that you can then test the contour, because actually the contour is defined by these 3 points on the tarsus and the angulation of these driving forces upwards. And so you can lift it up and you can lift it down until you're happy with it. And if you're not entirely happy, I'll go back one slide. If you're not entirely happy and you think it's too angulated, you can just loosen the knot here with a closed pair of scissors. And if you're still not happy, you can take out that suture and put it back again if you choose to. Quite often I found that I position my 3 plicating sutures rather too close to each other, and you might want to go back and put another one in laterally and medially if you need to. And there you see relaxing and lifting and relaxing and lifting like that until you've got it right and until you're happy, as you see here. So always check the conjunctival fornix to ensure that you haven't driven the silicon through into the fornix. I think that's extremely unlikely. It very rarely happens, if ever. And now we simply complete the pentagon. Just worth making the point again that this instrument has to drive down the periosteum before you then flatten off and come out here. And I always say to my fellows and colleagues, be very careful as you're driving it through, because you can prang the silicon. And here's the story. If you only make the tiniest nick in the silicon, you won't know it at the time. And then the problem is that it can break at the end of surgery, or it can break any time subsequently, but you won't know that you've nicked it at the time. So you've got to be super careful. Now, I am actually holding a pair of tooth forceps here, but you've got to be very careful about the instruments that you use. And here you see us completing the pentagon like that. And I'm lifting it and I'm dropping it. Am I happy with the contour? Yes, I am. Am I happy with the height? Well, that's the next bit, of course, and that's how we put the silicon sleeve on. So we're coming up to the sleeve, and I use it's called a Watsky sleeve, and it's 1.6 millimeter in diameter. Now, if you ask for a Watsky sleeve, chances are your staff may offer you a 2.3 millimeter diameter. It won't work. The ends will slip through, so you've got to go for something that's pretty tight, and you want about 5 or 6 millimeters or so. And here you see we put it through one side, and we're going to put it through the other side, and we're going to draw it through, and you'll notice immediately that I'm now switched over to Moorfield's forceps here. But if you want to see this schematically, there's one length going through, there's another length going through, and then with the gloved hand, of course, you can just pull it off at a little bit of speed, and you won't snag the tissue. If you want to, you can use a Watzke sleeve, which spreads the silicone sleeve, and it's a Watzke sleeve spreading forceps. If you've got them, they work perfectly well as well. The next question is always how much to tighten. Well, at the very least, you have to take up the latent tension within the lid. Generally speaking, in these patients, at least I found in my earlier days, I was tending to undercorrect them for fear of giving them corneal exposure. So I tend to lift them to about 1 to 2 millimeters above the pupil. But of course, it rather depends on the frontalis action. If you've got a good frontalis action, frowning, raising, let's say 7 to 10 millimeters, which is typically the case, you really only have to take up the slack plus a millimeter or two. But don't forget that over time, it's going to ease off, and that noose is going to come down in time. So when I started, I was tending to undercorrect them, and it's quite uncommon, in fact, to overcorrect them, despite your innate concern. Now, always leave a little play on the ends. You can see the silicone here. I've left, how much have I left? Well, if you leave too long, it'll pop out. If it's too short, then you won't be able to adjust it. So I probably leave about 5 to 8 millimeters or so on each side. Now, here's a tip that I learned from a senior colleague. You want these ends, let's see if I can show you on the screen, you want these ends to lie under the frontalis muscle here, but they won't go of their own accord unless you create a deep tunnel with a pair of forceps such as Stevens scissors, and you can put them in close and you make a tunnel where the green is. If you make a tunnel down here, what's going to happen? The knot's going to slip down and you're going to lose the advantage of the lift that you had in the first place. All right, so do not, I would suggest, ever create anything like a vertical tunnel. So never tunnel down here, even inadvertently, because it'll just slip the knot and you'll get less of an effect. All right, now here's the tricky bit I've always found, getting those ends back in. And time again, you'll find they pop out. And the answer is that you haven't created enough of a horizontal deep pocket. You won't cause any harm. You put your scissors in flat, blunt-ended scissors, put them down in, open them up, create that pocket. Because if those ends have to be pushed in to stay in, you can bet your bottom dollar they're going to come out later, sometime in the years that follow. Okay, so when you're finished and you look at this screen, you might just be able to see the glimmer of the deep Watzke sleeve here, but you certainly can't see any ends. And then, of course, you close it in the usual way. It's a deep suture, a deep circular mattress. And then you can see my little crisscross continuous butterfly suture here. Now, these incisions down here, they just simply require a straightforward single closure, as does the lid. And you can use a 7.0 for the lid as well. So what about the results? Well, if you look at these patients, the first one has CPEO, the second one has myasthenia gravis, the third one actually has blepharophimosis syndrome, if I remember rightly. And what's interesting about these patients is that they're all still using their eyebrows to pretty much the same degree, but in doing so, they're all lifting their lids. But I have found that when you've got a really bad case, and this poor young lady, in fact, actually, Thomas, she was from Cairo, and she came through and she had maximum brow lift, no lid lift at all. So she had a silicone sling. And if you look at the horizontal raphe here, and you look at the top of the brows, she's now able to relax her eyebrow, her frontal headache goes, and yet she's able to very gently manipulate the height of the lids with what frontalis function she wants to use. So when you've got a really bad case, they probably will have an improved headache, which they often come with, and they say they've got a frontal headache. And look at that brow that's now come down, yet she's still able to control and open the eyes. So what are the complications? Well, I think really, if you can call it a complication, slippage can occur. It's going to happen anyway as the tissues cheese wire through the silicone cheese wires through the tissues. But that's mitigated slightly and reduced if you suture it with the open sky technique to the tarsus, like I've shown you. But if it does slip, you can find the knot at the top. And under local anesthesia alone, the knot's usually slipped a millimeter or two. You find it. And with lots of blunt dissection, you can find the sleeve, you can pop it out, and you can tighten it again, as you see me doing on the right-hand side of the slide just there. But here's something I've learned more recently. Do not keep tightening at the top if, in fact, you found that the loop has actually crept up and is actually sitting up here. Because if the loop's sitting up here, you're much better off opening the skin crease, bringing down the loop, suturing it again, and don't tighten it at the top because you're robbing Peter to not pay Paul very much. And so increasingly, I might adjust it once at the top. I might adjust it once at the bottom. But if I'm still in trouble, I might take it all out and put a new one in. So the other complication that we do see is this exposure. And it is true that if you can bury that end of the silicone effectively, you won't tend to get that exposure, but it has to be deep with deep closure. And here you see it. I hope you can see it on this slide here. You can see this end just coming through here. And the question is what to do about that. Well, Certainly, if you clean it up and you bury it again, it might work. But quite often the inflammation continues and you have to pull the whole thing out. And then you might assume that if you do remove the entire silicone sleeve, your whole lid comes down and it's been a waste of time. But in fact, as I'll show you in this last slide or two, this gentleman had that very problem. We removed the silicone, and yet due to the fibrotic tract, strangely enough, he remained functional. So if you do have to remove the silicone stent, we're saying to the patients, look, don't worry, you may actually still have sufficient traction within those deep tissues, as you see this gentleman who even still had lag ophthalmos without any silicone in place at all. So in summary, there are challenges in dealing with these patients. The lid opening is very poor to begin with. They often have corneal exposure signs before you start, but do not think that you have to drop the lid if you do get corneal exposure. You have a range of possibilities to raise the lower lid. You could go for a medial lecanthoplasty in the elderly patient, but you'd be better off relaxing the lower lid retractor and or putting a spacer graft in. There is a tendency, I find, to undercorrect at the beginning of one's career, and that's probably true for most ptosis, but certainly in these patients, do not leave them undercorrected, because you can always let them down again if you have to. Do be prepared to adjust. Have a low threshold for adjusting. But also, and finally, my last point, don't always adjust at the top. Consider opening the skin crease again and adjusting the loop on the tarsus and suturing it back down to the tarsus. And you may find that the original surgeon had not ever sutured it to the tarsus at all. So that's all from me. Thank you very much indeed for your attention. I hope that's been pretty clear. And it gives me great pleasure, of course, to hand over to our colleague Tamer Gaudet from Cairo University, who's now going to talk to us about the complications of ptosis.
Okay. Thank you so much, David, for a very nice presentation, very illustrative, actually. Before I will start, I will ask you some questions, because actually we have a lot of questions here. So the first question is, how useful, for Miguel, actually, how useful do you find the phenylephrine test in predicting post-op TPS? And the person says your talk was very lovely.
Thank you
so
very
please,
much.
Miguel.
Thank you. Thank you for the question. I think it's very useful as to determine the degree of ptosis in the contralateral side due to slow. And I, in my experience or in my practice, I find that I give different relevance to the phenylephrine test depending on the patient. And depending on the relevance that I give to that test, then I do one thing or the other. There are some patients that are just slightly reactive to phenylephrine. And if I'm doing an anterior approach, I wouldn't give much relevance to that test. But still, may be useful to check how the contralateral side works. Thank you very much. I hope that this answers the question.
Yeah, it's very okay. Thank you. And next question is for Mike. What do you suggest for correcting ptosis due to trabeculectomy problem? After
I always prefer to do an external levator approach when there's a trabeculectomy bleb. And again, those can be challenging. So whenever possible, I'll do it under just local anesthesia or MAC anesthesia so that we can have some intraoperative assessment. And I always find that, again, I find that I need to advance that levator, tighten up that levator always just a little bit more than what I normally would have expected for just like a virgin aponeurotic case.
Okay, thank you. And another question is, what suggestions do you have for treating ptosis with poor levator function and ipsilateral frontal muscle damage from a previous accident? Dr. Verti, please.
So question to me. Well, generally speaking, if you've had an injury that's caused the ptosis, obviously we wait, and we wait up to 6 months, because you don't know whether it's an injury to the muscle or injury to the nerve or both. And the number of times I've waited and then found the lids come back has been very often. But if in fact you do have a reduced levator function and there is no diplopia in primary, so they have good extraocular muscle movements, then yes, I would certainly consider a silicone brow suspension, because you lose very little with it. It can be removed, it can be adjusted, and it's a very straightforward procedure. So I would have a low threshold for trying to lift a lid if they've had an injury. But having said that, the most recent case that I had, the injury itself is often associated with middle lamellar fibrosis in the lid, which means it can be quite stiff to lift however you try to lift it.
Okay, another question for you, David. Would you consider tarsal switch procedure or implanting a lower lid spacer to improve post-operative lag ophthalmos for patients with myasthenia gravis or progressive ophthalmoplegia? And do you think using permanent non-absorbable suture will decrease slippage of the sling?
Right, okay, I'll deal with the second question first, the age-old question of permanent versus not permanent. Basically, what is going to keep any tissue or any structure on a tissue is fibrosis. It's not the suture. So I very unusually use a permanent suture such as Prolene, but you can do, but it's the amount of fibrosis it's generated. And so I think that the order in these patients is to get the upper lid raised and then to deal with the lower lid. It's a bit like having a letterbox. You're just shifting the position of the letterbox. And I've had patients who've had to lift the lower lid. You can do a Prolene lateral tarsal support from the lower lid tarsus up to the periosteum, or you can put an alloderm, or you can put in a spacer. I'm not so keen on hard palate graft because it produces a lot of mucus, but you can do, or you can also support the medial canthus, although that's not so easy. But I would say if the patient has functional problems and they're a short patient, so they have to look straight ahead or up, then you're far better off lifting the upper lid and then lifting the lower lid if you have to, in addition to plenty of lubricants, etc.
Okay,
the other one or two other points.
Yeah, please go ahead. They're asking about the type of silicone
yes.
tube you are using.
Yeah. We use the silicone that we use in putting a stent for DCR. So it's a DCR stent in effect. And one of the other questions is, why do we open this? Why did we open it? Well, the reason is that if you just put the silicone through without laying over the orbicularis, if you just put it through as I used to in my first 10 years, that silicone will tend to rise up more easily than if you lay it on the tarsus and you put the orbicularis back over, because the fibrosis tends to keep it in place. And it doesn't take that much longer. And I think it's something that our senior colleague, Alan McNabb in Australia and others have been doing very successfully. And I think it is a better technique personally, but it just takes a little bit longer.
And last question, thank you, David. Last question for Mike. Do you do, in cases of traumatic third nerve palsy with ptosis, will you do the surgery even if will result in diplopia, or you are going to leave it?
Yeah, I think the diplopia is a real issue that the patients oftentimes don't realize how bothersome it's going to be for them, because when they're occluded, they don't have the diplopia. I oftentimes will put them through a trial with a little Ptosis crutch that has them walking around with the eyelid elevated so that they can experience it. Sometimes I'll actually ask that my strabismus surgeons correct or try to correct the misalignment and minimize the diplopia before we'll undergo ptosis repair. But I think it is something that what's most important is just counseling the patient, letting them know that their diplopia is going to be much more noticeable, and trying to get some guidance from the patient whether they can tolerate that and whether they still want to proceed with the ptosis repair.
Okay, great. Thank you. So now I will start my presentation about complications of ptosis surgery. So, Bismillah ar-Rahman ar-Rahim. Okay. So everything is okay now? You can see that, okay. So as we all heard now about how to do the ptosis and how to evaluate patients with ptosis, so it's very important, the evaluation and the decision making, what type of surgery are you going to do, and when you postpone the surgery and when you do it immediately. So all this will make you avoid the complications. So first of all, we have to know that there is a difference between the side effects and the complications, because side effects can happen like mild lag ophthalmos, or even if it is moderate lag ophthalmos, or which is the inability to close the eyes during sleep, especially in cases of frontalis sling, or even after levator muscle resection. But if the cornea is not exposed, it is okay to put lubricants and ointment, because usually with time it will become better. But in cases if the cornea, as you can see here, is exposed during sleep or during closure, at that time there will be some sort of corneal exposure, and maybe it will be troublesome for the patient, especially if it is severe, like in this patient. In such case, you have to interfere immediately to prevent corneal ulceration and corneal opacity. Usually, such case like the one you see now, it is caused by overcorrection, and the overcorrection usually occurs because of also bad decision during surgery. Patient with moderate or mild ptosis with the good function of the levator. So that's why it's very important to know the levator function before surgery to avoid over resection of the levator muscle and aponeurosis. Such case, because he came several months after surgery, so I cannot recess the levator, and I need to put a spacer. So I chose ear cartilage, and I put it with non-absorbable with at the mole muscle. The most important thing to keep the cartilage covered with the conjunctiva so as not to rupture. And this was the result. Maybe 1 week after surgery, much improvement of the lid position, and the cornea becomes wet again. So one of the most common complications that occur after surgery, ptosis surgery, especially congenital ptosis, is the undercorrection. And maybe many years ago, and I believe Mike can remember this, when we were in Bascom Palmer with Dr. David C., he taught us that you will never overcorrect a congenital ptosis. And actually, that's why we have to do in cases of congenital ptosis, especially with severe ptosis like the one you can see on the right side, on the left side, you have to put the lid margin at the end of the surgery a little bit overcorrected, maybe before. So in cases with congenital ptosis, especially if the levator function is poor or fair levator function, and moderate ptosis or severe ptosis, you have to, and you are going to do levator resection, plan to overcorrect by 2 millimeters at least, because this will fall, and to avoid such undercorrection. One more thing to do in such cases, examine is using the brow or not, because as you can see here, these two patients, the brow, he is as if he's not looking with the right eye, he's just using his left eye. This means that this eye is an amblyopic eye. So you have to treat amblyopia first, and then by covering the sound eye and try to treat the amblyopia maybe 1 or 2 months before the surgery. This will help the patient to look better with both eyes. As you can see here in this patient with moderate ptosis and fair levator function, also he's not using his frontalis muscle, he's not elevating the brow on the left side. So the decision is to make maximum levator resection, aiming for overcorrection after surgery, because as you can see with age, it will fall down, and then you can see here he is now young chap, and his eyelid in a very good position, the left eyelid. The same for this child with almost moderate to severe ptosis and fair levator function. He's using his frontalis muscle, but not so good, and the decision was to make levator resection, maximum levator resection. And you can see here, this is maybe 1 month after surgery, it is still overcorrected, but as time goes, he's a young chap, and you can see that both eyelids are symmetrical with the symmetrical crease, and he looks better because it will fall down. So to avoid this undercorrection, aim for bigger, or aim for more resection during surgery. Also, this patient with severe ptosis, and he is using his frontalis, the decision that was taken by another surgeon is to do levator resection. Actually here, the decision should be to do frontalis sling. Sometimes some surgeons do not like to do frontalis sling unilaterally, because he says not elevate this eyebrow. Actually, when you have a patient like this who is elevating both brows and he's very strong, you can do a unilateral frontalis suspension, and the patient will, as you can see here, even he doesn't elevate the brow so much, and still the eyelid in a very good position. Of course, when it is bilateral, it's much better, but still you can do it in unilateral cases, especially if it is severe ptosis with poor levator function. It's better to do frontalis suspension rather than do levator resection. Also, in cases like this with severe ptosis, you can sometimes do frontalis muscle advancement, and you suture the frontalis itself to the superior border of the tarsus. It gives a very good results in some patients, especially if the frontalis muscle is very strong, and the patient, as you can see here, after this frontalis advancement is feeling, looks very good. Another complication after successful levator resection is the crease and the lash ptosis. As you can see here, this patient, actually, she did levator resection, transcutaneous levator resection, and she was not happy. She came presenting with this fold of skin. She's saying that the eyelids, both eyes, do not look symmetrical. And actually, the main reason, because of this overhanging skin over the lashes that pushes the lashes downward, and also the crease. She is not happy because she doesn't have the crease, and she doesn't have this tarsal platform that Dr. Gonzalez talked about. So in such case, what you do is to reform the crease again and resect minimal skin to just show the crease, and suturing the upper, the skin edge to the upper border of the tarsus or to the deeper tissues to reform the crease. And in such case, the crease will be good. And by time, as you can see, that she looks much better after reformation of the crease and removing the skin. The same here also, overhang skin, because actually she did ptosis surgery, but the surgeon didn't excise the proper amount of the skin. She was very upset because she felt that she didn't do anything. Actually, I explained for her that the lid position is good, but the lid margin is in a good position, but the overhanging skin is the main reason for such a condition, and removing of the skin and trying to put the lid crease on the same level to the other one will manage such a condition. There is a problem here in this patient. Actually, I will tell you about it later regarding the contour and how to manage. It's very important to exclude cicatricial ptosis, because as you can see here, cicatricial ptosis brings, for example, after chemical burn, it brings the lid down. If you are planning to do ptosis surgery without removing this whole fibrotic ocular surface problem with using the amniotic membrane or mucous membrane, the ptosis will not will still be there after surgery, because it is mechanical, some sort of mechanical ptosis rather than muscle problem. Also, the incision site and removal of skin, especially in very young patients. As you can see here, this patient did ptosis surgery. She has actually an ugly scar, and even with time, this scar brings the lid margin in outwards like ectropion after ptosis surgery. She was not happy, of course, of such condition, and this makes the contour very bad. So you have to remove the fibrotic tissue and reconstruct the eyelid. Sometimes we need grafts, especially in young patients. Regarding the contour, it's very important to put the lifting suture at the pupil, the nasal edge of the pupil. Here, the lifting suture was in the center of the cornea and the center of the tarsus and the cornea, and that's why it's not with the pupil. That's why you feel as if there is a notching, or the highest point of the contour is not at the pupil size. It should be at the pupil level. Also, the lateral suture between the levator and the tarsus should be at the edge of the lateral limbus, because if you take the nasal suture, which is the lifting suture, at the edge of the pupil, and the other suture just beside it, not at the lateral limbus, you will have this nice surgery, but the patient is not happy because of this temporal ptosis. So it's very important after exposure of the levator aponeurosis and exposure of the upper part of the tarsus to suture the levator aponeurosis or the levator muscle exactly at the sites I told you about, to make a good contour and make the patient looks better. And it's very important to avoid suturing the orbital septum during your suturing, because this will magnify the lag of thalamus after the surgery, and even will cause a lot of notching to the lid margin. So if you follow these rules, you will get such good contour after ptosis surgery. And here even the patient is started to wear a colored contact lens. She was very happy with her surgery. Entropion can happen after frontalis sling, but could be transient, like in this patient, because of the skin hooding or pushing the lashes downward. By time, as you can see here, this patient, I didn't do anything for this patient, just follow up, and he's okay. After about 6 months, the lids look very good. But if you do evaluation, especially transconjunctival, without proper evaluation of the patient pre-operatively, like this patient who has a severe trachomatous changes on the conjunctiva, which was severe fibrosis of the tarsal conjunctiva and the forniceal conjunctiva, and also she has a lot of skin, although she is young. So the decision to do transconjunctival ptosis surgery here was not good, because she came with this bilateral entropion and severe spasm even in the orbicularis that marked the entropion even more. So it's very important, if you are doing a sling operation or ptosis surgery, to put your sling in the good position. It's not about 3 or about 4 millimeters from the lashes, also to avoid any trauma to the hair follicles and to avoid madarosis later, and to pass the sling to the frontalis muscle and how to adjust it. This makes things better. In cases of entropion, sometimes we need to put a spacer or ear cartilage, as you can see here in blue, the ear cartilage in front of the tarsus to make a support to the tarsus, especially if the tarsus is deficient or weak. Like in this patient who had an entropion also because of bad scar, bad vision, and near the lashes. So he had ectropion. Such case, we need to excise, to reopen the skin and excise all the fibrous tissue and release all the sutures to make the lid calm down, and then we think of frontalis sling later, because this patient will not benefit from levator resection. One of the, it's not uncommon, but you can see it in some patients, especially if you are doing maximum levator resection, is conjunctival prolapse. As you can see in such patients, if it is mild, you can do hot fomentations and lubricants, and actually you can notice it during intraoperatively, and it's better to avoid it intraoperatively if you are doing action in the upper fornix. And if it happens like this and you see it post-operatively, you have to do 2 or 3 matrix suture. You go with a double armed 4-0 or 5-0 through the conjunctiva, through the whole thickness of the lid, and tie the sutures at the crease to drag the conjunctival prolapse inside again. Or sometimes you can excise part of this conjunctiva. Granuloma is very common with frontalis sling, especially if you are using something other than fascia lata. Sometimes skin granuloma, as you can see here, you can treat it with local antibiotics or systemic antibiotics. Sometimes if there is an abscess, you can open this abscess. But if it is severe, like in this patient, and does not heal with or does not heal with treatment, you have to open and get out this infected sling. And if it is many months after the surgery, you will be astonished that the lid will be in the same place because of the fibrosis that inside the lid will keep the lid in a good place. Of course, bad scars are one of the most annoying things for patients, especially in patients with ptosis and telecanthus surgery. So one of the rare complications you can find is the extraocular muscle imbalance, and this should you, especially in cases with severe ptosis and levator resection, maximum dissection of the levator up to the fornices. If any suture take the superior rectus while you are suturing, or taking the tendon of the superior oblique, sometimes you have this extraocular imbalance. To avoid such a complication, at the end of the surgery, try to move the eye and be sure that the eye is moving away freely from the eyelid and they are not connected to each other. Otherwise, dry eye and or hematoma can be easily treated after surgery. So if you follow all the rules, and I think all the previous great speakers told us a lot of secrets, so now you can get good result after ptosis surgery. Thank you so much.
Thank you, Dr. Ashraf. So, thank you. Thank you, Dr. Tamer. If you please, can we go through the questions we have in the question and answer tab?
Is Mahdi back again to us, or he couldn't join again?
He's on his way. Okay.
He couldn't join?
No.
Dr. Mahdi Fender is with us?
He's trying to join right now. We can have some questions till we get him back.
Okay. He's asking, of course, in case of no ptosis and asymmetric TPS due to high skin fold on the pathological side.
Okay, can we connect?
With little fat to bring down.
But I don't have control of the.
Welcome back, Dr. Mahdi. We are now, we will have some questions related to Dr. Tamer's talk, and then we will start Dr. Mahdi's presentation.
Okay. Now, this question for Miguel. Miguel, do you hear me? Miguel? Okay.
Loud and clear.
Yeah. In a case of no ptosis and asymmetric TPS due to high skin fold on the pathologic side with little fat to bring down, is it feasible to consider microfat transfer rather than fillers?
Well, as I already answered that, but if you think that the lack of, if it's very important, first of all, that's one of the most difficult situations to treat, the patient with no ptosis and a high skin crease. You may consider correcting the crease in the other side, depending how high it is in the side that the patient is complaining, in order to achieve symmetry. Or if you want to bring down the skin fold, you may consider, depending where the problem is, that's why it's very important to check which is causing the asymmetry. But most of the times I see this problem in patients that have been or have had blepharoplasty, upper blepharoplasty surgery, and they have had some skin removed in one side, more skin removed in one side than in the other. So answering the question, you can consider fat pearls or dermis fat graft if you're putting the volume intraorbitally, just behind the septum, or you can consider both of the proposals that the doctor makes if you want to inject at the level of the subbrow fat pad, right? You can inject hyaluronate, or you can inject fat, depending, in my hands, depending on the volume, I usually go for hyaluronate.
Okay, great, thank you. So, Andrew, can you hear me, Andrew? Dr. Mahdi is ready?
Not yet, sir.
Not yet, okay.
I think some questions, they were repeated. For example, the hearing is low. So
Yeah.
I think they need to hear the opinion of the panelist for the hearings law, and the second, monorectomy in case of congenital ptosis. So,
For me, I don't do myellectomy in congenital ptosis because usually congenital ptosis needs something more more aggressive. You need to work on the levator and the molar itself. Maybe I do conjugalectomy in mild ptosis, acquired mild ptosis, and if the patient is positive for the phenylephrine test. What do you think, David?
I agree, Tamara. I try to, if possible, do a phenylephrine test and see if the eyelid responds. If it does, then I'll give the muellerectomy a shot. But usually, I find it's not adequate.
Okay. And what about you, David?
Yeah, I would agree with that. That's not going to be enough in children, is it? You really need to couple what levator function they've got with the tarsus, and shortening the muller is simply not going to be enough.
Yeah. And Miguel, you have the same.
Even if you have positive phenylephrine test in congenital ptosis, usually they don't respond like in Horner or adult type. So congenital ptosis, I think the pathophysiology is different. So frequently after even myellectomy, they tend to have the same all under correction.
Okay. Miguel, do you have experience with the conjugal myellectomy?
I have performed congenital myellectomy in children, and well, the results were very good in children that after the surgery I feel comfortable removing the suture. I haven't done congenital myellectomy in children using absorbable suture, but the results that I've got are quite very good, basically. And but it's not probably the surgery that I would be planning to perform in congenital ptosis in children.
Okay. Okay, Andrew, is Dr. Mahdi is ready now?
I think, yeah. Dr. Mahdi, you hear me?
Yes, Dr. Mahdi is ready, and Andrew, please join, share his screen, share his presentation.
Okay.
You can start, Dr. Mahdi.
I don't have the presentation. Oh, thank you. Thank you, Thamer. Thank you, Eva Pharma, and sorry for this problem of connection. I will speak about severe ptosis because I chose this subject because it can be sometimes difficult to manage in our practice. Next slide. Of course, the severe ptosis include all the cases with imported ptosis more than 4 millimeters and with very poor levator function, inferior to 4 millimeters. Next slide. And this situation is still with a therapeutic problem with many questions and many controversy, both for the first technique, should you prefer levator reduction or frontally suspension, and also for the second technique, should you move to frontally suspension or still with a second levator reduction. Next, please. Next slide. And for, no, previous slide. Next slide. And for the frontally suspension, there is still also some problems with is it better to do unilateral or bilateral suspension? Which kind of material should you prefer, autologous or alloplastic material? Next slide. For us, important factors have to be taken in consideration to make a decision, mainly the clinic aspect with the levator function. Is it more close to 0 millimeters or to 4 millimeters? Unilateral or bilateral ptosis, and also the etiology of the ptosis, is it congenital or acquired, and which cause of acquired ptosis, is it traumatic, progenitor, and also the quality of frontalis muscle. And of course, we have to take in consideration the age, the anatomic aspect of the muscles, and of course, there is the experience and the position of the surgeon and the position of the patient and his parents. Next slide. So in our practice, we still indicate frontalis muscle suspension as a first technique, mainly in case of synkinesis or severe traumatic ptosis or severe neurogenic ptosis or unilateral severe ptosis. And we prefer in general fascia lata, and if it's possible to prefer PTFE. Next slide. Here is a case with unilateral suspension. Next slide. But in our current approach, we prefer levator resection. But instead of the classical technique with a large dissection and large levator resection, we prefer the mini-invasive technique with a minimum of dissection. With this technique give us the possibility to keep intact the physiological adhesion, mainly of the interior part of the muscle, aponeurosis muscle, retinal ligament. And in case of severe ptosis, the technique is equivalent of the internal suspension on the retinal ligament. Next, please. Here is the classical approach with a large levator resection. Next, please. And our preferred technique is mini-invasive technique and mini-invasive levator resection with the minimum of dissection till the retinal ligament, and the amount of the resection is less important than the classical technique with a better effect to upper the lid margin. Next, please. Here is a case of mini-invasive levator resection as the first technique in severe ptosis. Next, please. Another case with bilateral severe ptosis, and in some cases, like we see here, we can have sometimes overcorrection, as we see in the right side. Next, please. Even in traumatic ptosis, we can use this technique. Next, please. And we can indicate this technique in case of hypotropia with ptosis. Of course, we have to treat hypotropia before treating ptosis, and we do levator resection with hypocorrection for a better correction, for a better protection of the cornea. Next, please. It is a case of ptosis with hypotropia. Next, please. And we can still, with the levator resection, even after the failure of first levator resection. So it can be available as a second technique with a good result. Next, please. Here is a case of mini-invasive levator resection as a second technique after failure of the first levator resection, and the result postoperatively, which is relatively stable. Next, please. In addition to mini-invasive levator resection, we propose in our cases the frontalis muscle flap suspension. Next, please. And we start with this technique mainly in case of severe traumatic ptosis, as you see in this case, with severe laceration of the upper eyelid and the result after the muscle flap, frontalis muscle flap, postoperatively. Next, please. And we enlarge our indication for this technique even for synkinesis, and to avoid suspension material, we do the frontalis muscle flap suspension in case of Marcus-Gunn syndrome. Next, please. In some cases, we can combine the two techniques when the levator resection is not enough to reach the level of the margin that we want to reach. We can add the frontalis muscle flap suspension to improve the result, and we see the better lead margin position operatively. Next, please. And we indicate it in this case of blepharophimosis, and the patient in this case refused any idea about frontalis suspension and any material to suspension, and this technique was helpful for this patient. Next technique, next slide. Another case with severe unilateral ptosis with combined technique, mini-invasive levator resection and frontalis muscle suspension. Next, please. So for the result, regarding for the palpebral opening, in general, frontalis suspension is better than levator resection, but with the mini-invasive levator resection, we can improve the result, and we can reach more than 70% of success rate. And regarding to the complication, we have much less complication with levator resection, with a stable result, and avoiding the material reaction and the material problem. And for the frontalis muscle flap, we have a good opening with no need of material suspension. Next, please. So in conclusion, in severe ptosis, frontalis suspension still this basic technique, but in our practice, our current practice, we prefer levator resection with a mini-invasive technique and the frontalis master flap, which can be combined, which is effective and avoiding disadvantage and a complication of frontalis suspension. But of course, it depends on the case and depend of the experience of the position of the surgeon and the patient position and the parent position. And thank you very much, and sorry for this problem of connection.
Thank you so much, Mahdi. It's very interesting technique. It was trying. It's very interesting, especially now it's the the mini invasive techniques and small incisions are on vogue, as they say. We have some questions. We have a lot of questions, but I'm happy that Dr. David and Dr. Michael answered many of them. Maybe we have one or more that's not answered. Dr. Miguel here, yeah. This is the questions. So there is a question for me about the scar, the medial scar, and what to do in a medial scar for telecanthus. Actually, these scars are very bad scars because it's the skin of the nose is usually had this big scars, especially if the patient is ready to make a keloid or something like that. Some of this scar, the scar, sometimes steroid injection, as you mentioned, could be beneficial, but not in. I don't like steroids because sometimes it causes some sort of skin atrophy and redness of the skin. Do you have any recommendations for scars in cases of telecanthus and in severe scars, eyelid scars after ptosis surgery? Any of the panelists has any? We'll start with David, for example. Do you have any recommendations?
Well, I think, so basically it's about collagen contracture, isn't it? And so the passage of time will usually result in the collagen thinning, and that can be speeded up with Vaseline, and you can spend as much money as you like, but basically I think it's the physical act of massaging over the area, and all scars will thin out in time. That's a fact. And I just advise people to use E45 cream or Vaseline cream. By all means, you can use bio oil, you can use vitamin E cream, but I have a strong suspicion it's just the physical act of massaging it and the pressure that's put on the collagen bonds that makes them weaker.
Okay, Mike, do you have any recommendation for that?
Usually if patients are complaining of scarring, I would agree with David that I would try to hold their hand and advise patients, and many times that's adequate. However, there are some patients that just feel better if they are using something. And I have been somewhat impressed with the creams that have like the fetal growth factors in them. And these creams are usually manufactured and marketed towards the aesthetic market for wrinkles, and I'm not convinced that they do very much for skin wrinkles. But in terms of hypertrophic scars, I have been somewhat impressed. We've had some patients that have had fairly noticeable improvements in a short period of time using these creams that have these fetal growth factors in them.
Okay. Actually, we have a lot of questions, but I believe most of them are answered. So to conclude this incredible actual session, I am so proud to be among all these eminent speakers. And actually, I myself get a lot of benefit from all the speakers today. And I'd like to thank Eva Pharma for such wonderful meeting and for such wonderful organization. And I'm happy that Mahdi could make it. He's back.
And the problem of connection, I don't see. Yes.
Yeah, but at least we can hear your voice, Mahdi. So I will thank you all, and I will leave final comment for all of you. So we'll start with Dr. Yasser, please.
Thank you so much for you, Dr. Tamer, and for Eva Farb. Thank you for all the wonderful speakers and for the participant as well and the audience. And we hope that we could satisfy them regarding ptosis and challenges of ptosis repair. Thank you.
Dr. Gonzalez.
Thank you very much, Tamer. Thank you for organizing that, and thank you to Andrew from IVA Pharma. It has been a very nice experience. It has been the first time I do a webinar, so I will try to get better and better with the program and everything. So hopefully we'll be able to do another webinar in the near future. This has been a lot of fun. Thanks a lot again.
Thank you so Thank you. Dr. Muhammad and Dr. Andrew told me that it will be ready on the YouTube, so anyone can see it on the YouTube later. Dr. Berti, your comment, please, your final comment.
Well, I just want to thank all of our registrants. We've still got 311 people with us, and these are difficult times we're all in together. And I think ophthalmologists face particular risks, and you know, I think are very brave people in what they do in treating their patients. I think that this has forced our hand. I think that we have been led to do something that we should have started perhaps a while ago. Necessity being the mother of invention. I think we will need to do more of these. We'll find out ways of doing it better. I'm always told I should smile more, which is probably true. And I think that we can impart knowledge without always having to travel such vast distances. I very much hope that our participants have enjoyed it. I've certainly enjoyed working with the team here. Tamer, you put a lot of work into this, as well as IVA Pharma, and I just want to say thank you. And I very much look forward to working with you and any other colleagues to do more of this in the future as we try to build our capacity to deliver teaching and training remotely through these platforms with better bandwidth that's improving all the time. So thank you so much indeed, Tamer, and thank you very much indeed, Andrew, at IVA.
Thank you.
Thank you. Thank you so much. It's our pleasure. Dr. Yan, please.
Yes, I would echo all of those comments. Thank you so much, Tamer, and to IVA Pharma, and to the participants as well. It really is challenging to get such expertise to come together from around the world, and this is a wonderful venue to do that. So I think this has been an eye-opener, hopefully for all of us, and hopefully we can continue this in the future.
Thank you. Thank you so much. I believe we can do it in the future, very near future. And now, Mahdi, your final comment, Mahdi.
Yeah, thank you. Thank you, Tamer, to choose this subject, and thank you for all the speakers. It's the first webinar oculoplastic session. Has Miguel the first time for me. Sorry for the problem of connection from Tunisia, and hope to do the same in the future. And thanks for all the speakers, and thank you again, Tamer and IVA Pharma.
Thank you so much, and I hope a healthy life for all of you and all the participants, and stay safe and take care of yourselves. And thank you all. It was great, actually. Great. Thank you so much. Thank you so much. And see you all very soon. Thank you so much. Okay.
Thank you.
Thank you, Andrew.
Thank you.
Muhammad.
Thank you.
Okay. Good night.
Thank you, Dr. Tamer. Thank you all. Thank you.
Thank you all.
Have a great night. Thank you.
Good night.
Bye bye.
Good night. Good night, Tamer.
Good night. Good night, everyone. Bye bye.